We will get started on this webinar please put a comment in the chat if you're having any difficulties seeing anything at all, and we'll get started. Thank you very much everyone for joining this webinar, Bowel Cancer Screening for ACCHOs. The evidence clearly shows that the ACCHO sector has a vital role to play in expanding participation of Aboriginal and Torres Strait Islander people in the National Bowel Cancer Screening Program. And this webinar is a starting point, and we've been working with the Department of Health, looking at ways to support ACCHOs to be involved in this way. This webinar will be recorded and available online after the event for participants if anybody would like to join and share. Before we go any further, I'd like to invite a fellow cancer team member from NACCHO, Joel Madasek, to start us off with acknowledgement of country.
Right, testing. Can everyone hear me all good? Sweet as, microphone works. All right, Debari, good day. I just want to acknowledge the Ngunnawal and Ngambri people of the traditional custodians of the land in which we are teaming in from down here in Canberra. I want to extend that acknowledgement out to the traditional custodians of the land in which everyone else is gathering from today. And I also just want to extend acknowledgement to all the Aboriginal and Torres Strait Islander people that are joining us today, and say thank you to everyone, all peoples who are participating in the webinar today. And yeah, hopefully we can get some stuff out of it and it works and everything goes really well. And I'm going to handball it back to Kate.
Thank you very much, Joel. And I'd like to acknowledge that I'm dialing in from Aranda country, and I'd like to pay my respects to elders past and present, and to Aboriginal and Torres Strait Islander people on the call today also. Thank you. We're really thrilled to be able to offer CPD, continuing professional development points, to participants today through NACCHO and RECGP, depending on which organisation is appropriate for yourself. There'll be an evaluation square at the end of this webinar, a QR code, and we would just ask that you click on the QR code and click on the QR code. Sorry, someone has just taken control back there. Click on the QR code and complete the evaluation, and then we will be in touch with you to share a certificate of completion. During the webinar today, please share any questions that you may have in the chat box. We will have dedicated question and answer sessions after each learning objective. If we can't get to all of the questions, we will be in contact via email with a list of information that answers to the questions. The learning objectives that we're looking at covering as part of the CPD coverage for this webinar, we'll start off. Sophie Dwyer, another member of our cancer team, will be looking at providing some background information on bowel cancer screening, risk factors, just the broader scope. Then we'll be touching on some key learnings that emerged from the Menzies bowel cancer pilot. What did we learn about challenges and enablers for Aboriginal and Torres Strait Islander people to join the National Bowel Cancer Screening Program? From there, John Lee from Telstra Health will be sharing some of the nuts and bolts, the nitty-gritty logistics of bowel cancer screening in ACCHOs. How do you order your kits? How do you access the register through your PIMS? Those sorts of questions. We have a couple of videos that we're very much hoping people will be able to watch. And then finally, we have a terrific panel that will join us in a yarning session, looking at supporting community members with bowel cancer screening. So huge thanks to the team from Waminda, and also Kath Keenan, PHMO at AHNMRC, who's worked as a GP in the sector for many years, and our very own Casey Luttrell from the NACCHO cancer team. We have a lot of different panelists here today, but we also want to acknowledge that we're really just at the start of the journey. We've been working with the department, and thanks to Georgina Newton, who's also on the line, if we have some questions that we'd like answered. But we're really learning from you. So if there are questions we can't answer today, then please bear with us. We will go away and find out the answers to your questions and provide the information to you after the event. We also have another face-to-face session, training session coming up soon at the NACCHO conference, and Joel will be telling us more about that at the end. We'll be holding some more webinars. So we just want to acknowledge that this is the start of the journey, and we hope you get the answers that you need today, but if not, we'll keep learning together. So at this point, I'd like to invite Sophie to kick us off with Learning Objectives 1 and 2, if I may.
Thank you, Kate. Thanks so much. So just hoping everybody can see what I'm seeing there at the moment. We're on the Learning Objectives screen. So I just also, before I begin, I would also like to acknowledge the Ngunnawal and Ngambri people, whose country I'm dialing in from today, and pay my respects to elders past, present and emerging. Now, as Kate said, I'm just going to give a little bit of background and a bit of context regarding bowel cancer and bowel cancer screening, and why, sort of this model that we're discussing today has come about to enable ACCHOs to access screening directly. So, as many of you are likely well across and well aware, bowel cancer is the third most common cause of cancer-related death in Aboriginal and Torres Strait Islander people, and there's a significant gap in survival rates. Now, the reasons for this are complex, but ACCHOs have done and continue to do great work in this space. And as Kate said, we hope to provide a bit of an opportunity to share some ideas and learnings and some tools to continue this work. So, hopefully later today, everyone will be receiving a packet, a resource packet, and within that will be a flip book with some of this sort of imagery. It was prepared by the Department of Health and shared with us. But I'd just like to acknowledge that this particular image and several of the other images we'll see today have been used with permission and feature the beautiful artwork of Jordan Lovegrove, was the artist. So, for a very brief recap of bowel cancer, it is common, it may not be clinically evident, it is generally treatable if diagnosed early, and we can screen for it. And just so that we're all on the same page, when we're talking about bowel cancer, we mean cancer that develops from the inner lining of the bowel, depending on where the cancer begins. Bowel cancer may be called colon cancer or rectal cancer, or the broader term of colorectal cancer may be applied. And of course, cancer can start in the small bowel, but this is considerably more rare. So a key feature is that bowel cancer is usually preceded by growths called polyps. Many polyps are harmless, but some may become invasive if undetected factors. So as you're likely aware, there are a number of known risk factors for developing bowel cancer, but age of 50 years or over is by far the strongest risk factor. So family history in this context refers to close biological relatives, such as a parent or a sibling or a child who developed bowel cancer before they were the age 55. Or if a person happens to have 2 or more close relatives who develop bowel cancer at any age. There are a small number of people who have genetic conditions that might also increase risk. So we're just going to move on to slide 10 now, bowel screening. So given the ubiquity of those risk factors and the fact that if found early enough, bowel cancer is usually treatable, it makes sense to screen for it. So when we talk about bowel screening, it is important just to highlight that we're not talking about diagnosis. Screening is only for people without symptoms, and the purpose is to detect early disease, so early bowel cancer or polyps, or more strictly speaking, the indicators of those, which in this case is traces of blood in the poo, otherwise known as fecal occult blood. On slide 11 now. So for people with potential symptoms of bowel cancer, such as bloody stools, fatigue, anemia, abdominal pain, or a sustained change in bowel habit, unintentional weight loss, they should not be screened, but rather referred for diagnostic testing. On slide 12 now. So how do we screen for bowel cancer? In Australia, it is free, typically done at home using a fecal occult blood test, or FOBT, which is done on 2 samples of poo. So it doesn't require any changes in diet or any other special preparation, but it can't be done where blood from other sources might contaminate the test, such as a bleeding hemorrhoid or blood in the urine. So you'll see here on this slide, slide 12, is an image of the home test kit and its contents, which includes a reply paid envelope, so that people might send the samples to the pathology laboratory directly. Now, this mail-out home testing system is all coordinated by the National Bowel Cancer Screening Program. This program began as a pilot in 2002, and over the last 20 years has been expanded and progressively rolled out so that it's now offered every 2 years to all eligible people between the ages of 15 and 74 years. It's funded by the federal government and has been shown to reduce illness and death from bowel cancer through early detection and prevention. And just moving on to slide 14 now. So because eligibility criteria has changed over the years as the program has been expanded, it's worth highlighting that to receive a screening kit under the National Bowel Cancer Screening Program, you must not only be aged between 50 to 74, but also registered with the Medicare or Department of Veterans Affairs, the DVA, excuse me, and haven't undergone screening in the last 2 years. So when we say undergone screening, I should be clear here that we mean not just having done a fecal occult blood test kit, but actually received the result as well. So likewise, if someone has had a colonoscopy in the last 2 years or is booked in to have one soon, then they don't need to screen using an FOBT at that point in time. So for those with symptoms of bowel cancer, a pre-existing bowel condition or a family history of bowel cancer, they're advised not to screen, but rather see their doctor or healthcare provider. On slide 15 now. So screening kits are sent out by mail using data from the National Bowel Cancer Screening Register. So as we'll actually hear from John in a moment, the register stores information about the screening participation of eligible people and results of those who participate. At the population level, this is used for reports about participation rates and health outcomes, but more importantly, at the individual level, the information is meant to provide a safety net by generating reminders. There are state and territory-based program follow-up function officers, PFOS, who can help participants after a positive screening test results, such as by calling to see if that person has spoken with their GP. And so as you can see from the infographic prepared by the department, there is a considerable gap in screening participation by eligible Aboriginal and Torres Strait Islander people. So this leads us into thinking about some of the challenges and enablers to bowel screening for Aboriginal and Torres Strait Islander people. But just before we do move on, does anybody have any particular questions about anything we've just covered? Please feel free to jump in, throw up a hand. Yep, so we've got a question. Anna? Oh, Iona, sorry, I'm not sure who was first.
I don't know either. Sophie, the mailing list used by the Bowel Cancer Screening Program, is that an internal mailing list or a Medicare address list?
We'll throw to Georgie and John on this one, but I believe it's the Medicare mailing list. But John or Georgie, do you want to chime in?
Yeah, that's right. It's we take the address details from the central Medicare database.
Thanks, Anna. Great question. Kylie?
Yeah, I just wanted to clarify. The fecal occult blood tests that we do at our workplace quite often are not the kit. They're just with the local pathology provider. Do those results somehow make their way to the register or not?
John, I might try to do that one to you as well.
No, those results don't come through to the register because it's the National Cancer Screening Program for the cervical and the bowel programs operated by the Australian government. We receive the results for the government program kits only.
Yeah. I think that kind of changes the numbers a little bit. I don't know how many ACCHOs use only the kits or the local pathology providers. Anyway, just a thought.
No, look, I think you're completely right, and I think there are other issues with the sort of data sources as well. No, it's a very good thought, and I believe that's what this model is sort of heading towards trying to address. So, is there a question from Charlene?
Yeah, just clarifying on that. Do our GPs need to start, ringing the bowel cancer screening to update that the FOBTs are being done, or?
Glad you asked. It's coming up. Perfect. Brilliant anticipation. So hang five, and we will come to that. All right. And Sharon, is there a question from you?
Yeah, just a question. So the stats that you put up about the 27% of Aboriginal and Torres Strait Islanders, is that only the national, or is that including the pilot program that we did about 2 years ago? And also, because we are also using the FOB and our pathology service because the kits are really hard to come by.
Yeah, so this stat was taken from, I believe, towards the end of that pilot. Georgie, do you have any more information on where this particular stat came from?
Yeah, so I guess the infographic that's currently on the screen, those figures are based on the 2021 National Bowel Cancer Screening Program's, our monitoring report. So they are, the 27.3% is across the entire program in terms of Indigenous screening level. So it would incorporate Aboriginal and Torres Strait Islander people who participated in the pilot, as well as people who may have screened outside the pilot, but through the mail-out model of the program.
Right, thank you. All right, well, we might head on into the next section, which is just having a bit of a look at sort of some of the common challenges that we encounter sort of more broadly before sort of drilling down into some of the challenges that are a bit more specific for communities. But you can see here that it's one of the things that was flagged is that it's only really been since 2020 that that sort of age range was expanded out to include people between 50 and 74, and there was a bit of a viewpoint that perhaps screening isn't necessarily seen as something that comes under the purview of primary healthcare because of this sort of national register approach. But there are also certain challenges with the centralised mail-out model. My apologies, we're on slide 18. There are certain challenges that are more specific to communities, and these included things like that mail-out model that relies on the Medicare or DBA registration, and that addresses, as Anna highlighted, you need to have have a fixed address with a reliable postal service, which many people just simply don't. But there were also many issues with the kit itself, as the information was quite dense and predominantly written rather than visual, plus the need to take 2 samples and store in the fridge, which may not be possible for everyone, and sometimes there may be a sense of embarrassment or shame due to the nature of the samples required and bowel cancer more broadly, as well as mistrust of institutions or a sense that screening would not actually achieve anything. So slide 19 now. So to address some of these challenges, a year-long pilot was developed by the Menzies School of Health Research and was trialled, where bowel cancer screening kits were delivered to participating ACCHOs and primary healthcare centres to give eligible Aboriginal and Torres Strait Islander clients directly. It ran from November 2018 to October 19 with variable experiences and feedback overall, but bowel cancer screening participation did actually increase from 23% to nearly 40% at participating sites. So it's important to highlight that by delivering the kits to ACCHOs directly, the intent is not to replace the usual mail-out system, but to offer a more sort of user-friendly way of engaging in screening. Patients and clients at participating ACCHOs still can complete their screening through the usual pathway if they prefer, and that's the norm. So if they haven't completed a test through their ACCHO, they will still receive one in the mail. So on to slide 20 now. So what were the main learnings? And beyond the increase in screening rates, some of the other key features from the pilot were that people generally really would like their trusted, and that's the key word there, their trusted healthcare provider to raise bowel screening with them in a way that's culturally respectful but normalises it. So on 21 here, we can see that there were we've just got a few sort of examples and quotes which came out of that pilot and consultations around that pilot. And they've actually informed some of the resources that have been developed and really highlight a strengths-based approach. So common elements are the need to have bowel cancer screening messaging that is really clear as to why it's being done, how it will be done, and what will happen afterwards. And ideally, it should be routine, acknowledging that there are significant sort of logistical challenges to that in and of itself. So I think if we bear that in mind, this is probably a good point to hand back to Kate to introduce the alternative access to kits model, and then we might throw to John.
Thanks very much for that, Sophie, and thanks everyone for bearing with us with the technical issues, but they seem to be sorted now. We'd welcome any questions that people might have at this point. The next section that we're going into is really, as I mentioned, the more technical logistics aspect that John Lee will be taking us through. John's the Head of Engagement and Communication with the Telstra Health National Cancer Screening Register's Engagement and Communication team. That's quite a mouthful. But John, if you would like to take control and start on your section, were there any questions before we hand it over to John, though? It doesn't look like we have any questions at the moment. There'll be a question and answer time after John's section as well. So thank you, John.
Thank you so much. I'm so nervous about taking control of this screen, and I'm really hoping that it works. So I'm going to move my slide, and if somebody can tell me if they can see the next slide, that would be great. Yep. Oh, Thank goodness. Well, thank you so much for inviting me to come and speak to you all today. Thanks to the NACCHO team. I'm over in very sunny Naarm, and I'd like to begin by acknowledging the traditional custodians of the land that I'm presenting from today, being the Wurundjeri people of the Kulin Nation. And I recognise their continuing connection to land, waters and culture. And I'd also like to pay my respects to elders past, present, and any Aboriginal or Torres Strait Islanders on the call today. So I'm going to provide a quick overview on the National Cancer Screening Register. I'll refer to it as the NCSR or the register, just to give it a little bit of context there as well. And I'll be touching on the digital channels that are available for healthcare providers to give you a better understanding of how the register can support the alternative access to kit model when ordering and also when handing out kits within community or within clinic. So we're all collectively here today because we're working towards increasing participation. And of course, we know that the recommendation from the healthcare provider is one of the most impactful things when someone is deciding whether to screen. So having the person's NCSR screening record available in real time and accessible by healthcare providers will hopefully help to prompt some of those really important conversations with patients in clinic or when out in community. So the National Cancer Screening Register is a digital platform, and it's developed to underpin the Australian government's National Bowel Cancer Screening Program and also the National Cervical Screening Program as well. So it's designed to support the end-to-end operations of the programs to help achieve that shared goal we have of eliminating cervical cancer by 2035, which is the current target, and also by saving over 80,000 lives from bowel cancer by 2040, if we can increase the participation rate to 60% within Australia. So the National Register has been supporting the cervical screening program since 1st of December 2017, which is aligned with the renewal of the program, and has been supporting the bowel program since November 2019. So we now have that one record for each participant of the two programs. I've just changed my slide and I'm hoping that worked. Nods, great. So what does the register actually do? So it's not like a repository, like a cancer register or a clinical audit register. As I said, the NCSR manages all operations of the programs from go to woe. So we work with our Mailhouse and Sonic Healthcare, who manage the IFBT kit creation, and we send out about 1 million pieces of correspondence each month. So that includes the invitations, the reminders, and the mailed out bowel test kits. So we also process the results and put those results into the participant record within the register. So each week we receive about 20,000 cervical screening test results, about 2,000 cervical histology reports, and about 25,000 bowel program test kit results. So as I mentioned, they're directly ingested into that participant's record. So then the rules engine, which is built into the register, which is based on the clinical guidelines, it uses that data that's received into the participant record to apply the appropriate clinical pathway for each participant, which will then trigger the next action that the person needs to do. So whether that is maybe getting a negative result, so then they're invited again routinely in 2 years, or if it's a positive result, then it will trigger a follow-up by either the healthcare provider or directly from the register, or by one of those participant follow-up function officers that was mentioned earlier. So then the data is then available to Australian Institute of Health and Welfare, to states and territories, and to the Commonwealth to monitor clinical safety of the program and inform program policy as well. So our goals really is in supporting all operational aspects of the screening programs is really the main focus is to maximize participation by identifying, inviting, and reminding eligible people to screen when they become due. So the register enables that follow-up function of screen detected abnormalities by applying those automated, nationally consistent clinical rules with the clinical algorithm. and that single screening record for each eligible participant in Australia, accessible in real time, provides healthcare providers the information they need to support people on their screening journey. And the register also informs continuous improvement and evaluation of the programs by providing that data to the Commonwealth, State and Territory and IAHW. And as I mentioned, that's really to support the safety, the quality, the monitoring and evaluation of the cancer screening programs, and to inform any policy development and service planning. And then, of course, one of our other big objectives is to create that connected ecosystem, if you like, to make sure that that information is available to everybody that needs it in real time, and that that information is securely accessible by healthcare providers and participants through the MyGov channel, or by pathologists as well. And we're connected with all of the pathology providers and Sonic, who distribute the kits. So we're going to look a little bit closer at those digital channels that are accessible by healthcare providers, and we'll learn more a little bit more about the alternative access to kits model, how to order the kits from the portal, the healthcare provider portal, and really importantly, how to inform the register when the kits have been handed out. And I can't stress how important that is. So I'll just move my slide on. So the healthcare provider portal is accessible via PRODA, which allows healthcare providers and people like yourselves to complete a range of activities. So through the healthcare provider portal in PRODA, you can access your patient's bowel and cervical screening results and histories online in real time, and also see the next screening action. You can submit program forms electronically, and also manage your patient's participation within the screening program. So we do get the address details and the demographic details from Medicare, but these can be updated within the register, within the participant record specifically. Sometimes a patient may want their cancer screening information to be sent to a different address than they have all of their other Medicare correspondence being sent to. And you can also order an IFOBT kit, which can then be delivered directly to that patient's address. Slightly different to the alternative access model, but we'll touch on that later. So healthcare providers are required to authenticate themselves through the creation of a PRODA account. I'm sure many of you are familiar with PRODA or already have a PRODA account, but PRODA stands for Provider Digital Access, and it's an online identity verification and authentication system used to enable secure access to government online services. So not just for the National Cancer Screening Register, but for HPOS, NDIS, and PRODA is also used by healthcare providers when they're applying for the new provider numbers as well. So healthcare providers need to link their PRODA account to the NCSR upon the initial registration by clicking on the NCSR tile. So you open up PRODA, and you can see a number of different services available for PRODA, like HPOS, NDIS, and there's also the NCSR tile on there. So you can click on that, and we'll talk a little bit about linking that later on. Something else we'll touch on is integration with clinical software. So I'm sure you all use some sort of clinical software, whether that be Communicare or Best Practice or Medical Director. So we've enabled an integration directly into those systems, which we'll touch on a little bit later as well. Okay, so what are we going to cover today? So we'll cover the ordering of the kits in bulk to your clinics. So noting some of you will have already put in an order with the Department of Health or may have already received kits in bulk. But what we'll go through today is how you can order kits yourself from within the portal from the 31st of October when that goes live. We'll talk about identifying patients who have not screened for bowel cancer. We'll talk about how to search for your patients in the portal. And we'll touch on handing out a kit to your patient and informing the register about that. So this is probably the most important piece. So once you've handed out a kit in practice or in community, it's really crucially important that the register is informed about that. So I'm not going to go into too much detail about registering for a Proda account, because I'm sure the majority of you will already have a Proda account. But if you want to access the healthcare provider portal through Proda, you can either do this by going to Proda itself and logging into Proda, or there's also a button on the ncsr.gov.au website at the top left there, which takes you straight to more information about the healthcare provider portal and how to link through to the portal there. So linking accounts can be done with a Medicare provider number or a register identifier number, or also known as a state and territory access number. And these numbers and that second option there, they're available for health professionals that are providing cervical screening tests but don't have a Medicare provider number. And on that third option there, that's for administrative staff or other nurses or other healthcare providers that don't have a Medicare provider number. And they can access the portal by requesting to be a delegate of a provider with a Medicare provider number who is already registered on the portal. So with that third option there, you can click on that and it will ask you to enter in the Medicare provider number of the person you're requesting to be the delegate of. And once you've done that, they will then log into the portal themselves and either accept or decline the delegation. And of course, this is all necessary to make sure that the right people are accessing this really sensitive and private health information in a secure manner. And the last option on there, that relates to registering your organization within Proda to access registered data via your clinical software like Best Practice Medical Director or Communicare. So the register is integrated with those three software vendors. And some of you may have already integrated your system with the register. But the integration essentially means you can access that screening data and submit forms from within your patient records within your clinical software. And we'll touch on this a little bit later on. So I'm going to play a couple of short videos, and the first one is showing you how to order the kits in bulk that will then be delivered to your practice. And I'll probably pause after that one and see if there's any questions.
So you've logged into the healthcare provider portal, and along the top is the button for IFOBT bulk orders. Click here to start your order. Before ordering kits for the first time, you must complete some short training to understand the alternative access to kits model and your role in it. Once you've done the training, the ordering process should only take a minute or two to complete. Click on Start Order. Because you've already logged into the portal as a healthcare provider, the IFOBT bulk order form will pre-populate several fields. You will, however, need to enter your clinic name and phone number. While the address of the clinic will pre-populate, a different delivery address can be entered. This address won't change the address held in Medicare, it will just be for this order. Next, you need to decide how many kits to order. They're ordered in batches of 10, with the recommended number per provider being no more than 30 kits. More can be ordered if you have a large eligible patient base, but the kits have an expiry of about 7 months, so keep this in mind when calculating how many kits you need. You will also be asked how many healthcare providers the request is for, how many kits you currently have in stock. If this is your first order or have run out, the answer here can be 0. And if you do have kits in stock, whether any are expiring within 4 weeks. Capturing this information will help minimize kit wastage and ensure kits are available as needed. Click Next. If you order 30 kits or less, you won't see this screen. If your order is for 40 or more kits, you will be asked for a reason. This helps us better understand how large orders of kits will be used. Options include awareness raising, promotional campaign, kit distribution in hospital, or another reason. Click Next. Lastly, you will see your order confirmation. If you have any changes, use the Go Back button. Check the acknowledgement and confirm you understand the requirements of kit storage and distribution, then submit your order. The next page confirms your order. The tracking number will be displayed on the IFOBT bulk order page within 10 business days. Only your most recent tracking number will be displayed in the portal.
Okay, it mentions at the start of the video there is a training link, but essentially this is the training, so you're not going to need to do that on the first order, but by all means feel free to do if you would like a refresher. I'm gonna, as I mentioned, I'll pause there and see if there are any questions. Kylie. You just unmute, Kylie.
How do you access the register through Communicare?
I'll touch on that a little bit later, but what needs to happen is that you register your organization in PRODA. So instead of like what you do for the healthcare provider portal within PRODA, you register your organization. So a lot of practices are quite familiar with that because they've needed to do it with Medicare Web Services to access things like Australian Immunisation Register. And that's what you need to do to integrate with the NCSR. So you can speak to somebody within Communicare. They've got lots of guides and support to be able to access that integration. But yes, a lot of people are much preferring to access through their integrated software rather than the portal because they can look at the patient screening information from within the patient record directly in the system. But just to note, ordering kits in bulk must always be done through the healthcare provider portal in PRODA.
Okay.
Thanks, Kylie.
Thank you.
Any other questions? Give an awkward pause. Okay, great.
To get started, search for the participant. Click on the active link next to the Bowel tab. Under the form area, click on Choose a Form and select Alternative Access Model Issue Reissue Kit. Next, confirm and update where needed your patient's participant details, including address, nominated healthcare provider who will get a copy of the results, and where applicable, the person's personal representative, Indigenous and country of origin details, if applicable, and your patient is happy to share this information, and self-care, mobility, and communication details. For example, if somebody needs help with a test or language translation. Click Continue. The next page asks you to select a reason for issuing the kit. The system identifies by postcode whether the participant lives in a region where the average monthly temperature is currently over 30 degrees Celsius. Samples need to be kept cool for as long as possible, as heat can impact the performance of the completed kits. It's recommended to offer the test kit to patients during cooler months, but this can be a judgment call by the issuing healthcare provider if they see a clinical benefit. If you select Yes to proceeding, you will be asked to provide the date you issued the kit and its expiry date, found on the back of the kit, and confirmation that your patient has given consent to receive this kit from you. Next, review the form. If any details need to be changed, you can do this by clicking Edit. Once the details are correct, press Submit and Print. Then wait while a participant details form is generated. This may take a few seconds. Then print the form. Give the printed participant details form to your patient and remind them to complete the dates the samples were taken. Sign the form and include it in the prepaid envelope when they send back their samples. Once you submit this form, an icon will display on the participant's bowel record. This shows healthcare providers with access to this patient's record that this person has received a kit via the alternative access model for this screening round. If you need to update and reprint the form, click on Reprint Participant Details Form. You'll see a timestamp is added to show when the last alternative access model issue-reissue kit form was submitted. Before reprinting the form, check or update the details as needed. To assist with patient follow-up, go to the My Correspondence tab. Here you will see notifications showing if a result has not been received or is inconclusive. You may need to scroll to the bottom and use the slider. Use filters to refine your search. This is a prompt for you to encourage your patient to return the completed test kit. This section also displays notifications when the patient is due to be issued a kit for their next screening round.
So this is probably the most important step out of everything, is registering that kit through either the healthcare provider portal or through the integrated system. So when we send out a kit through the standard mail-out model, all of those kits are, of course, barcoded. We know exactly who they've been sent to, and when they come back, we know where to store those results, to which participant or patient those results need to be stored against, so that the pathway can be updated. But with the kits that are sent out in bulk to a practice, they're not barcoded because we don't know who they're going to be issued to. So it's really important when handing out that kit that you enter this information as you've just seen there, and that is then linked electronically to that participant's record. So you can print out the form and give it with the kit. And then that means that we don't get kits back. We don't know who those results are for. So that's a really, really important step that everyone within the practice handing out the kits should know. And that's one of the reasons why there's the training link in there when ordering the kits, to make sure that people understand that step. Now, there are a number of videos available, including these, that are available on YouTube. So we have a National Cancer Screening Register playlist, which talks about registering for the portal, talks about how to search for a participant and how to submit forms, all of that kind of information, if you wanted to check back and look at this information again. I'm going to skip slide and hope that it doesn't replay the video, so bear with me. Woo. Okay, again, I'm going to pause for questions after that video. Nope. Okay, so I've touched on most of this already, but what we've done is okay, it started playing again for some reason. It stopped there. Right, so I've mentioned that we've integrated the National Cancer Screening Register with Best Practice Medical Director and Communicare. So that essentially means that you can do, except for the ordering of the bulk kits, you can do everything that I've just mentioned in the portal, but you can do it from within a patient record. So let's take Communicare as an example. You're in the patient record. Once the integration has been enabled within the system, there's an NCSR hub. So when you click on that in the patient record, it brings up another screen, which is essentially the register's information within Communicare. So you can see the address and the demographic detail that are stored within the register. You can see the next screening action, or when they're due to screen next. And you can also submit program forms, including the form that we've just demonstrated in that video. So that will all be enabled. The alternative access to kit model will all be enabled within that integration from the 31st of October. Now, I realize that may generate more questions, so I'm going to pause again and just give 30 seconds there to see if anyone has any questions. Sorry.
Sorry, John. Yeah, we have one question there from Sharon Kendall.
Sharon.
John, is the integration of this bowel screening, is that in an update, or we can activate it like this afternoon?
So you will be able to activate it within Communicare Medical Director if you have a recent version, so within the last year or so, which I'm pretty sure most people are quite up to date now. But the step that you need to take is to register your organization within PRODA. And that is essentially so that we are aware who is accessing registered data, because it is such sensitive information. So you can take that step within PRODA when you register the organization. Some people can find that a bit of a tricky step. So what I'll do is I'll send you a link that you can click on, which can it gives you the option to book in a time with one of our digital specialists at the register, and they are more than happy to walk you through exactly how to do that. So the person in the practice that needs to register the organization in PRODA is the responsible officer, and they will enter in the details. Once that is enabled and you've enabled the software in either Best Practice Medical Director or Communicare, then you'll be able to access it. So a bit of context there, we've probably got around 25% of practices that are eligible, that have these three systems. We've probably got about 25% that have already taken that step to integrate with the register. And the feedback has been really great because they don't need to then leave their system, log into PRODA, check the screening status and all of that, and they can do it directly from within the patient record. So I will send that link as soon as I've stopped presenting and figured out how. Any other?
If you could share that link with everyone, a request has come through for that, please.
Yeah, no problem.
And Sharon, I think that's another question, Sharon? Or maybe it's a legacy.
Just one question. Will the bowel screening and the registering, will that ever come in line with how we do it with the cervical screening? Less documentation?
So could you expand on that a little bit? I'm not sure.
So with the cervical screening, we're doing the procedure with a pathology request, and that goes across to the register. Will the bowel screening ever fall in that kind of line, or we'll still have to do the documentation to register?
Register the integration or register the kit?
Register the kit.
So with the traditional mail-out model, the kits are already registered. It's just with these kits that you're handing out in practice that we don't know exactly where that particular kit is going to. They'll always need to be recorded and registered within the software.
But we don't have to do that when we do a CST. So we get a CST vial and that just gets sent.
Yeah.
There's no registration involved.
Or even with the fobs that we send to pathology.
I think the tricky bit with the bowel kits, when you're handing out the kit in practice, in clinic or in community, the reason why it needs to be registered and that form needs to be printed to go with the kit is because if that form didn't go with the kit and the kit was handed out and the person completed the kit and sent, and it goes directly back to Sonic, they mail it out just like they would with the usual model. When it gets to Sonic, they don't know who the kit has come from. So that's why that registration step is so important to link it into the register.
But I think what's being said, though, is that the bowel cancer screening program seems incredibly cumbersome. There is not, it doesn't matter who you are or where you are when you're taking a CST, when you're doing a cervical screening test, the results will go to the register. But not with it. I mean, we do countless fecal occult blood tests on a weekly basis, but just with our local Dorevitch. So, none of those results are going to the national register.
Yeah. Well, lucky we've got Georgina on the line from the Department of Health, who might be able to cover that question.
Okay.
Thanks, John. So yeah, I guess like John's, I think flagged previously, at the moment the register only holds the clinical results for tests that are distributed through the program. So I guess it is, there is that data gap in terms of bowel cancer screening results that are done outside the program. Look, I've made a note of the feedback around the program being cumbersome and the interest in kind of all the results being captured through the register, and we'll feed that back to my director, and I guess it's something we can look at when we're looking at improvements to the program further down the line.
Thank you. There's a couple of other questions, John. One from Marty. Are there any plans to integrate with other clinical software, for example, MMEX?
We would absolutely love to. So Marty, if you were to get in touch with MMEX and say you would really like this functionality within your software, I think that'd be great, and they can feel free to give them my details. So we've created a non-proprietary FHIR API, which essentially means that any vendor can connect to the register. They just need to do some development work on their side to connect to the register. So it's fairly new technology in terms of these integrations with the first three, and these are essentially the first three that we have integrated with so far. But to create that connected ecosystem, we want to connect with everyone, as many vendors as possible.
Thank you, John. Anna, question from you.
Yeah, I had a question that it's related to that issue of the general pathology fecal occult blood tests not going to the register. The register is linked to Medicare because it's using Medicare address. And my understanding, I think this is correct, if Medicare registers a colonoscopy, the fecal occult blood test is not sent out to the patient. Is that correct? Yeah. So if Medicare also registers a fecal occult blood test that's being done in a pathology centre, because there's a pathology item for it, in my mind, it should be easy to link those two things together. One, the result, but also, would you send out a screening test to somebody who's already had the pathology test done by their healthcare provider?
Yeah, so I think the trickiness around that is mostly around consent and around legislation as well. So that's one of the reasons why only the program test kits are sent to the register. So I think that's probably what would need to be looked at in terms of collecting data from other pathology results that haven't necessarily consented for their data to be on the register.
Thank you, John. I can't see any other questions there at the moment.
Sharon have her hand up again. Sharon? Or was that a legacy one?
Oh, there was just one thing that I just wanted to add is that if we are registering the kits, if we have the option of doing a kit and a FOB test with, say, pathology, like what's the chances of a service going with the pathology, because it's going to be less paperwork. And it's also going to affect the data as well. So there's 27% of Aboriginal and Torres Strait Islander clients completing the kit could be higher if the FOB kits, the FOB tests were also added into that data.
Thank you, Sharon. We'll definitely be following this up with the department after the webinar. So I think these are really important points. So yeah, thank you.
Yeah, absolutely. So just this is the last slide that I'll touch on, but I will share that link in the chat where you can book in some time to speak to one of our digital specialists. If you have any questions about accessing the healthcare provider portal through PRODA, or having some issues with doing that, and also around registering an organisation so that you can access this information directly from within your clinical information system in practice. And I'll share that link as soon as I've finished. And that's it from me.
Thank you very much for that,
Thank
John.
you.
I'll take back control there, and that was just your final slide there, John, with some contact details, I believe.
Yeah, that's right.
Great. All right. Lovely. Okay. Well, we're moving on now to the final section of the webinar, and this is a really exciting opportunity to hear from the team at Waminda, also from Kath Keenan, and also from Casey, as mentioned before. I'll just start with the first instance, just opening the floor up, and I think the team from Waminda are already setting the standard with some great questions there. But Sharon, can I share the floor with your team? Really, this is an open floor. We'd just love to hear about your experiences. You're part of the model, but of the pilot trial, but also since then you've obviously been doing a lot of health promotion activities and a lot of screening. So we'd love to hear your stories, if that's okay.
Thanks, Kate. Yeah, we have been a part of the pilot program back in 2018-19, and we did come across some challenges as well, as some good data as well, because we targeted the bowel screening, and we had a specific worker to target that and do the follow-throughs and the recalls as well. So we did find it benefited our data and getting our clients to do the bowel screening, because they just weren't doing the government one that was getting sent home. So some of the barriers which have already been mentioned is that shame factor, and nobody wants to talk about a bowel motion, never alone to stab a bowel motion as well. So just to try and normalise bowel screening and how you do that. And then getting sent the demonstration kits to actually demonstrate to the client exactly how it's done was good also. So other barriers are storing the specimen in their fridge. They didn't want to put it with their food. So then we would have to organise transport to go pick it up and then make sure it got sent away. Just the paperwork. It was another barrier. There was like the part A, part B, well, pretty much what is now, but the hard copy version of that. And we had to develop our own pilot flowchart as well to make sure that clients did fit the criteria to have the test performed, and then just to make it clear across for all staff what the pilot project was about also. We were finding, and we still are finding, that some bowel kits that are from the government are lost or misplaced or just put away to never be found again. So that's why we were doing the FOB kits here at pathology as well. And yeah, so yeah, just the stigma around just poking a poo really. And getting over that and talking about and knowing and looking at what is actually in the toilet bowl, and normalizing that so people are aware of what's normal and then when to escalate any medical needs as well.
And then having to physically take those samples to the post office was also the challenge, because, you know, the postmaster knows exactly what's in that kit and people don't want to have that, even that interaction. So like Sharon said, we used to transport and pick them up and take them ourselves, so people didn't have to have that interaction.
Was there any, you know, have you got any advice around staff, helping staff to feel confident about having that yarn with clients about it? Casey will be talking about some resources we've got to share, but do you have any advice on that front at all?
Our clinical model is Aboriginal health practitioner led, so definitely making sure that they are trained up with the clinical process, the terminology, so that then they can develop and make it culturally safe for our clients as well. So I think, yeah, I think we've done really well with explaining the process to our clients. So we are Aboriginal health practitioner led here.
Yeah, we developed.
Because even, yeah, and it was good to have the kits as well that were had the Aboriginal design on it. I know these ones are the Sonic Healthcare ones. So that was also a good thing as well.
Thank you. You mentioned having the kits. Have you found that doing it, what prompts doing the screening? Is it, you mentioned when we've spoken in the past about, for example, having health promotion days and handing out kits, or is it when you're doing the 715 health assessment, or is it a recall system? What processes did you have in place that really helped you, you know, prompt the bowel cancer screening process?
Everything that you just said. So we made it a generic recall for everybody over 50, and then it would sit in their recall to-do list in Communicare. Then our triage nurse would then be prompted to have that conversation with clients. We have pamper days that we run and go into communities. So we'd have yarn up groups, yarn up sessions, and then target our cervical, our cancer screening. So especially bowel screening. So then have a yarn up circle and demonstrate exactly what needs to happen. And then, yeah, and have the clients then the opportunity to have a discussion as well.
And champions for recalls. We did all of it.
Last one there.
Sorry, we also had staff that were champions of doing the recalls for bowel screening or cervical screening, so they would take the lead.
Actually, yes, Casey's got some updates on that. That's terrific. Thank you. Does anyone have any questions for the Waminda team while we're going? And one other question that I had, did you have systems creating recall lists and reaching out to people, or any other sort of systems using your Communicare? Can you talk us through that?
We just put the recalls in. Communicare wasn't that helpful in regards to that, and then it was just that champion ringing clients. It was our triage practitioners having the conversations as well, going through.
Mentioned, I think too, that having the kit and opening the kit up and walking people through, that was useful.
Yeah, so each consult room had a demonstration kit in it. So if needed, they could open it up and then look exactly what's in it. Yeah, and go through the process. It is, yeah, it can be daunting if it's you're new to it and it's, you know, you're putting that piece of paper down into the toilet, which, yeah, so having that conversation and demonstrating of exactly how you do it. and less handling of stuff as well.
And the kits were really good because they had that piece of paper. So if you go with a standard FOB from, you know, your usual pathology provider, there's no documents on how to do things. So the kits were fantastic on that.
Yeah.
And there was 3 in the pathology ones. There's only 2 in these ones. So that was even helpful again.
Great. And we will have some resources, and there'll be the opportunity for members to adapt them themselves. Charlene's just asking, how would we go about getting some demonstration kits? They would just be the empty kits, I think, some blank kits that haven't been registered. Is that correct, John, that as long as a kit hasn't been allocated to a particular client, it could be allocated as a demo kit?
I think some kits have recently been sent out that are demo-only kits, and they're essentially old kits that have expired and should not be completed in real life.
So our team will follow that up, Charlene, and make sure that there are plenty of demo kits. Okay, lovely. Are there any other bits of advice that you might have, Waminda team? It's been fantastic hearing from you. Thank you so much. I guess some the resources that will come through will just have some other information on it, such as we don't need to ask clients to change what they're eating or to stop taking any specific medicines before they do the tests as well. So that's reassuring. And if just this extra information will come in the resources that come out, that if someone has bleeding in their urine or hemorrhoids or other reasons why there might be blood when they're passing a stool, then to have a yarn with their GP about that. So thank you so much, team, for those insights. Really appreciate it. We might come back to you with some more questions at the end. But Kath Keenan, if I can throw the platform to you, please. Just talking with clients, you've worked as a GP in the sector for many years. It's obviously reassuring if the test is negative, but how would you start to have that conversation with the client if it's come back as being positive?
Oh, thanks, Kate. I'd just like to say that I'm coming to you joining from Gadigal land and pay my respects to the traditional custodians, past, present, emerging, and to all the Aboriginal and Torres Strait Islanders joining with us today. And thanks to the Waminda team. If we had that sort of team everywhere, I don't think we'd have such a problem with getting people screened. The conversation, I mean, it's always hard. I guess it starts with advice when you're giving out the kit is about expectations of responding, and I'm sure that the Waminda team are already doing this, and just having a chat to them about what happens when the results come back. And then I guess, obviously, if you already know the result, if it's without, you know, like, if there's consent, having a support person with the client who may have a positive result. And hopefully if they've already been advised that just because you get a positive result and need to go on to the next step doesn't mean that you definitely have cancer. I think that that's a really important message. And then I don't know what other people's experiences have been, but sometimes even with a positive result, there's a reluctance to go on and have the next step, the colonoscopy. So that, I mean, the FOBT is a huge thing for a lot of people, but going on and having to go and have a procedure done can be an even bigger step. And I think, Kate, you'll send her a resource on that can be useful about explaining to patients what is involved in the next step. So just making sure, I guess, that the patient, that whole shared decision making, so that they very much feel that they are involved in this decision to go on, and that this decision is about trying to make sure that they stay healthy, and it doesn't mean it's just cancer. It could be other conditions that can be treated, and making sure that they feel safe in that decision. So they might need they might need to come back with a family member, or maybe they're comfortable with another staff member. It just depends on the situation and on the client themselves. I'd really ask what who they would like to have with them. And sometimes they don't actually want anyone with them. The other issue is if they don't want to tell other people. I think someone mentioned shame before, you know, so it's so hard to answer just with one answer, because the main thing is to individualize it and make sure that it's a really a shared decision, and that they feel empowered in that decision and the next steps, and they know what's going to happen and have plenty of opportunity for questions.
Thanks so much, Kath. And sometimes there would be, I guess, anxieties if there are waiting times around colonoscopies, although the evidence shows that colonoscopy sort of anywhere up to 120 days or 4 months won't adversely affect the patient's prognosis or outcome. But do you have any comments around that at all?
I think that it is important. It's always hard to have that balance between reassurance and making sure that people do follow up with their care. But that anxiety whilst you're waiting, I guess if you aren't able to change the time, and I would really sort of say to any clinicians out there, really you can advocate and you can push, and there are ways to access, and it can be difficult. But if you can't control that, if you can't manage that, then I think it is important to reassure, and it is important to say, look, this is a screening test. Most people, this is not cancer. You know, it's these few months waiting. But I mean, it is very difficult to reassure if people are highly anxious. So I think all the normal things you would do when someone is feeling anxious, and supporting them with their mental health, and involving whoever needs to be involved, whether it's staff members or whether it's family members or friends, or who they would like to be involved. Because that anxiety is real. It's a very justified anxiety when you've been told you've got an abnormal test and you need to have this done. So really validating their concerns. But if you can't get them an earlier colonoscopy, then I think you need to reassure and just support them through that time.
And I'm sure that NACCHO's cancer team would really appreciate hearing from members who are really struggling with referrals, if that is happening. Thank you, Kath and the Wominda team. I'll be handing over to Casey now to talk about resources. One of the resources relates to hot zones. John's touched on that previously. Casey, can I hand over to you?
Sure, thanks, Kate. I'd also just like to acknowledge that I'm on Ngunnawal country today, and would like to pay my respects to elders past, present and emerging. So as Kate mentioned, there's some resources that I'll briefly just cover that may be helpful to health professionals when talking to community members about bowel cancer. So as Soph mentioned earlier as well, we'll send out a link after the webinar that will have the resources in there for you to access and download. The resources that NACCHO have put together, they are templates, so ACCHOs may wish to customise them and tailor them to meet their community needs. So the NACCHO resources, they're actually separated into health professional resources, which you can see on the screen there are all the blue resources, and the community member resources are in the yellow. The Department of Health have also shared some great resources as well that health professionals may find useful in the clinic space. So you can see on the screen there, which some of you may be aware of, is the flip chart and the checklist, which has some good discussion points on there. The hot zone policy or hot zone resource might be a helpful one. There's 85 ACCHOs located in hot zones, so it's just got some helpful tips on there about how to manage and utilize the kits the best way that you can if you do live in a hot zone area. And then those other resources on the screen are some helpful guides, some frequently asked questions that health professionals might get asked in a clinic setting. And then the other resources are some step-by-step guides about setting up a proto account or getting into the register if it's your first time, which can be a little bit tricky, but that will hopefully have some step-by-step guides for you as well. So you're welcome to download those and use them in the clinic space. And then these resources here are really tailored towards the community members. The two Department of Health resources there, how to do the test and the bowel cancer screening poster, might be useful promotional resources that you could use. The how to do the test actually has a QR code on the back of it. So if there's people who do have access to a phone, they could scan that QR code and it will link them to a video to help walk them through how to do the test. And then the final one is the guide for community members, which NACCHO has developed, and it's got some just frequently asked questions in there that community members might ask. So they're welcome to take that home, or it might be a resource that could be used, accessed in the clinic space.
Thank you very much, and we'll send all of those resources out. Casey, did you just want to touch briefly, with, just in closing, about these next steps, about some funding and support?
Sure. So there's just some available small amount of funding that NACCHO will provide to participating ACCHOs, and that funding will just be able to provide ACCHOs with the opportunity to maybe create some community awareness events, maybe some health promotional tools, and tailor the resources to help encourage community members to participate in bowel cancer screening. And then we'll be also upcoming, there will be some themed polo shirts available soon, and that will be available to help ACCHOs maybe start the conversation about bowel cancer screening with their community members. So thanks, Kate. I'll pass back to you.
Very much. So we've really come to the end of our webinar, and if people are able to use this QR code to access the evaluation, we can also send out the link to the evaluation. If you complete the evaluation with your details for CPD, we'll be happy to arrange a certificate of completion for you. And I guess just in closing too, please don't hesitate to reach out to the cancer team if you have any questions at all. And I'll just close by handing back to Joel to have a rave about the conference that's coming up too. So thanks.
Sweet as, thanks, Kate. So yeah, just recapping, we've got that conference, the NACCHO conference coming up starting on the 17th of October is the youth conference. We also got our EGM and AGM on the 18th of October, then the members conference on the 19th and the 20th. If you can get down to Canberra or you send a representative down to Canberra or something, it'd be awesome to sort of see you there. And I just want to say that the feedback that we're getting from this webinar is awesome, because the whole idea is to make things as easy as possible for the people on the ground. And we're all here, like John was saying earlier, to support First Nations people, Aboriginal and Torres Strait Islander people through their cancer journeys, and that's what we're trying to do here. So all the feedback that we're getting back from you fellas is just absolutely awesome. And we're going to be at the conference with the cancer stall there as well. So if you see us, please come up, have a yarn. We're going to have a suggestion box there as well to sort of get more feedback from the sector. So come down, have a yarn with us. The whole cancer team from NACCHO will be there. We're really encouraging, we want people to come and have a yarn with us and tell us what's happening out there and how can we help. And that's what we really want to do. So we'd like to see you there. If you see me, I'm Joel. So make sure you come up and have a yarn, say hi, and then let's see how we can improve things. I guess that's the whole point of this.
Very good. Thank you, Joel. Just put it back on the code there for people who wanted it. We'll leave that open for a couple of minutes. But really, we've come to the end of the webinar. I really want to thank everybody very much for your contributions, for helping us to get the information out. As Joel said, we've got lots of key learnings that we'll take away, and we'll keep on working. But we look forward to keeping working with you. So thank you, everyone. And hopefully we'll see you at the conference, or we'll keep staying in touch. Thanks, everyone.
Thank you.
Thanks, Kate.